So the story of botensilimab and balstilimab is an interesting one, and I think we've learned a lot from this drug. There's both design features of the drug that we thought we were doing and things that we learned as a consequence of those design features. So we know as a fact that the immune system can cure cancer. Okay, I don't think anyone questions that. And we know as a fact that conventional immune checkpoint blockade is entirely ineffective in microsatellite stable colon cancer. You should think of microsatellite unstable mismatch repair deficient as an entirely different disease. But in microsatellite stable disease, every clinical trial of standard immune checkpoint blockade really is negative, and you have to squint at it to seek some response. We also know that every tissue in the body has its own sort of set point of immune suppression and how it contributes to how the immune system works. And that becomes relevant when we're using immune therapy on cancer. The way botensilimab works is not just as a CTLA-4 inhibitor, and that's an important thing that it does. CTLA-4 is going to promote activation of peripheral T cells, for example, but it also engages NK cells. And the thing that we have to remember is there's not just T cells residing in the lymph nodes, in the gut, in the blood, but there's a halo of regulatory T cells encasing every tumor throughout the body, at least tumors like colon cancer. And those T cells have to be cleared to allow an effective immune infiltrate. So you need to replace your suppressor environment with an effector environment. And this drug recruits NK cells where it binds CTLA-4. And so you're pulling out the Tregs and you're inserting NKs, and you're also creating a more potent activation of the APC to T cell sort of synapse. And so you accomplish several things, which is you clear the regulatory environment and you more potently activate the immune system. But the therapeutic index, so to speak, the amount of activation that you need in each organ is different. And the amount of activation that you need in, for example, the liver may be high enough that that's going to generate itis in other tissues. Whereas the amount of activation in other tissues is moderate enough that you can reliably give this agent with a much more manageable safety profile. So I think a lot of details will come out in the accepted but not yet published paper in Nature Medicine on this, so I have to be careful what I say. What we see here is a disease control rate, in the 70 to 80% range, and that's the combination of stable disease, partial responses, and complete responses. What we see is a significant duration of response, and the longer we treat people, the longer that's getting, because there are very, very long responders in this population. And we see lots of notable findings. This is working in KRAS wild type, KRAS mutated, BRAF mutated, every population it's working. We're seeing efficacy in lung mets and in peritoneal disease and in nodal disease. So lots of different subtypes are deriving benefit. And I think it speaks to sort of the power of this drug. It really is the first new multifunctional checkpoint blockade combination, period, and showing efficacy in this particular disease, which is common and incredibly morbid and incredibly lethal. And we have to keep in mind that now the leading cause of cancer-related death in adults under the age of 50 for men is colon cancer. And by 2030, it will be that for women. It will surpass breast cancer. We would expect that this drug will work similar to other immune checkpoint blockades in more immune responsive cancers like melanoma, lung cancer, things like that, where there will be a subset of individuals with a prolonged tail, with prolonged disease control. What do we call those people? I think in modern oncology we don't have a definition yet. People want to say things like cure. I think that's a word that we're a little uncomfortable with still. I would say there's excellent prolonged disease control for patients, both on drug and even for patients who come off of the drug for some reason, who've achieved a vigorous immune response. The immune system has memory and will persistently manage these cancers, either as chronic stable disease or as a true complete response.